Good morning, everyone. Thank you for attending another Workshop Wednesday with us here at the League. My name is Jennifer Slattery, and I am the Director of Training and Membership. We're excited today to have joining us from the Executive Office of Health and Human Services, Assistant Secretary Anna Novais, and Chris Ashura from the Rhode Island Department of Health. Both are going to talk to us about health equity zones, and I'm going to let them go right to it. So thank you for being here, Assistant Secretary.
Thank you. Thank you. Good morning for the invitation. It's great to be able to talk to you all. We've been wondering, in fact, how to have a even better engagement with the cities and around Rhode Island. But I want to start by saying how grateful and how proud we are of the work that we've been doing together with the cities and towns in Rhode Island. And while the concept in general of health equity zones may be a little abstract for some folks, in reality, on a day-to-day basis, our health equity zones have been working from the get-go very closely with the cities and towns, with the municipalities, and with distinct parts of local government. And our attempt today, what we wanted to do is really have that conversation, share with you all of the examples of the things that have been going on well, and then explore in a conversation how we can collaborate even better. What are the opportunities out there for us to work better together, and for the cities and towns in Rhode Island to truly benefit from this local infrastructure that we've been creating and investing in for the past almost 10 years now. The history of the health equity zones goes that far. 10 years ago, basically, when I was still at the Department of Health, in fact, one of the things that we were focusing on was in terms of addressing population health, looking at how well as a state we were doing. So we were looking at our data and realizing that Rhode Island, as many other states, we were doing very well in some population health indicators, things like immunizations. We do an excellent job immunizing our children. Things such as addressing the environment, childhood lead poisoning, we were doing very well. In other things, we were not doing so well. With diabetes, we were not doing so well. With substance use, definitely, and we know that today, more than ever, we were not doing so well. But the other thing that gave us pause at the time and made us think through what is that we are doing. One was that when you look at the different at the population a little more deeper, and you look at race and you look at ethnicity, we saw that people of color had across the board much lower less good outcomes than the white population. But what really gave us pause was the fact that the next generation, so my children's generation, for all of you who are my age, your children's generation. And so they had a lower life expectancy than we had. And that makes you pause and say, how is that possible? How is it possible that in a country like the United States, with so much resources, with so much richness, so much potential, we have a generation that has a lower life expectancy than the previous generation? That was the first time we were seeing that. And so we ask ourselves, how did we got it so wrong? What is that we need to change so we do not keep having the same results? That's where the idea of challenging how to do public health initially, that was our focus. That's how we start talking about the health equity zones. And the other thing was looking at this first slide in front of you. When we think about what drives really outcomes, and usually we say health outcomes, but in reality, life outcomes. When you look at that, you see that the things like schools, education, jobs, the kind of neighborhood where you live, the behaviors that you have, those count for almost 80% of the things that impact one's outcomes in life and in health. Clinical care, the one-on-one interactions with the doctor, or what you bring as genes and biology from a genetic perspective, those count only 10%. My kids used to say, thank God it's just 10%, Mom, because we do not want your genes, but that's a whole different thing. But then you look at it and then you say, okay, we are investing most of our funding on only 10% or 20% of things that matter. And the other 80%, we're not investing in really changing them. And that's because when you look at how folks have traditionally do things, and you look at the pyramid to the side, public health had traditionally invest in education and counseling, telling people what to do, eat 5 vegetables a day, run half an hour, all of those things. We have a lot of clinical interventions, but we don't really invested in those things that really make a difference, which is the base of that pyramid, improving the social and environmental factors of one's life, the housing, the education, developing, creating economic opportunity. We didn't see those as being public health. And so that's the change that we needed to effectuate and invest differently. And so the health equity zones come from that perspective. How do you invest at the bottom of that pyramid? It is what it means being focused upstream. It's focusing on the things at the base, the things that are going to make you change, focusing on the community in which one lives. And so the health equity zone, it's focusing upstream, so the bottom of that pyramid. It's place-based, meaning that we want to look not at a population specifically, or not at a group of diseases, but we need to look at one community and look at all of the factors in that community that we were referring to, schools, employment, all of those factors, and invest and understand what's the needs, the strengths of that community, that place, and what is that we need to change and invest in that place so it changes the place where people live. And we want the things that, yeah.
I'm sorry to interrupt. We're still seeing the first slide. Should we be seeing a pyramid?
Yes, so it's not moving for you?
It did not move.
Don't we love when those things happen?
Always.
It's still not moving. And I checked it before with Chris and he said it moved. So I don't know. It did before, so why is it not moving now?
Do you want to stop sharing on it and I can share for you and I'll just advance for you?
Yes, absolutely. So let me stop sharing, and it's not letting me stop share. Stop share. Okay. Did it stop sharing?
There we go.
Okay, so Chris will do it himself. And so the pyramid that I was referring to, in fact, it's a way of thinking about public health. So as I was referring to the 80% of the things, you saw it to the side and on your right side. So you can see that pyramid, the things that really impact one's outcomes, it's that bottom of that pyramid, the housing, the education, and public health has not invested on it. We always invest in things that are at the top of that pyramid, telling people what to do and so forth, and those have the least impact from a population health perspective and require the most individual effort. So you want to make things easy for the population. So the next slide, it's the one that's talking about the health equity zones and how we need to advance to a more focused upstream approach. And we did that. We started little by little. We first invested in a series of initiatives with what we call the health equity and wellness. We call them the CHU grants. CHU is not a good name for these, but those were still focusing on populations and it wasn't really changing. So the next slide talks about the health equity zones initiative. And it's really focusing on the base of that pyramid, as I was saying, place-based, meaning that we're focusing in one community at a time, one zone. That's why we call it zone, one specific place in a map. And we want to make sure that we are doing things that are truly transforming a community, that have lasting impact and are not transactional of nature, on a sense that they happen once, they are good, but they don't last and they don't have impact that is sustained. We needed to make sure that we had an active partnership with the community. It cannot be about us telling people again what to do. The community, we need to rely on the community, the voice of those who live in those places, to tell us what's important to them and how to go about changing their community. And so we needed to intentionally build capacity, invest in building that capacity at the local level, because we don't have it. We didn't have it, and we still don't have it in all of our communities. So the next slide talks about how we see the health equity zones framework, all of the different components of that health equity zone that creates, so focusing on building that collaborative, being the place-based, as we discussed, having the community tell us from their own perspective what are their strengths, their assets, their needs, and adding to that needs assessment that is community-driven, also the information that we have, so we have a global big picture of what's happening in their community. And then have the community prioritize what they want to do and come up with a plan of action, solutions that they identify with, that they own, and that they want to see us advance. And us as a state, we took a step back and we committed to not only support that infrastructure, but then invest in the plan that the community wanted to put forward. The next slide, it shows you how we see that change within the community. And for us, it's truly thinking about what did we believe needed to happen. And we believed that if we had these comprehensive, aligned, community-focused process, and we align all of our funding that before we were using in a very disparate way towards investing in that community, in that plan of action, we will be leading to really sustainable, meaningful change, both on the environmental conditions of that neighborhood and on the population health outcomes, and in general, improving the quality of life for the people in the community. So our health equity zone collaboratives, and this is an example from Central Providence, but if I was to take away Central Providence health equity zone and just say health equity zones in general, what we see across the board, it's a variety of sectors that are engaged, that really represent the life in the communities and in your cities, our cities and our towns, because we have people from the environment, we have people from education, we have local municipalities for sure, from city hall mayors directly involved, to departments of recreation, public housing. We have social services, both at the local level and at the state level. We have folks focusing on economic development, chambers of commerce, local business. We have the agriculture and food systems from, again, state level and local city level. We have housing. And most important for me, also not most important, but one of the most important really components, we have the residents, across the life course. We have youth, we have seniors, we have parents. They are all a critical component and equal partners in this collaborative that we created. The next slide shows you a picture of where we are with these health equity zones and how they have truly from initially 10 years ago covering, we had one in every kind of area of the big counties in Pawtucket, I'm from Pawtucket and I have Pawtucket in my mind when I think about health equity zones. We had the counties represented, but we know that in Rhode Island, counties don't really govern through, we don't have a county governance. And so we wanted to make sure that, most importantly, we were covering cities and towns. And so while today we have 15 health equity zones, you can see that we are covering 26 out of the 39 city and towns. And we have 80% of residents being served on a sense by EOHHS. So it's a tremendous coverage, but really our goal, it will be to have every single city and town at minimum covered by a health equity zone. And in some instance where it makes sense, as for example, the city of Providence, we have neighborhood level equity zones, South Providence equity zone as an example, West Elmwood. So very focused at the community level, or Pawtucket and Central Falls came together as two cities and created one health equity zone. But so they differ from place to place, and it's been really good for us to see that expansion, and we look forward to see even more of it. So the next slide, just busy slide, and I'm not going to read through it because you'll have these slides for you. It just shows you who we have right now as a health equity zone, the geography where they are located, and then who is the backbone organization. And the backbone organization is an important concept because collaboration doesn't happen naturally. We know that. I had a mentor that used to tell me that human beings are the least collaborative in nature. And so we need to force kind of collaboration. So we do not want to force collaboration, but we want to support that collaboration. And so one of the ways that we support that collaborative process that happens within the health equity zones, it's to truly support what we call a backbone organization. And the backbone organization is one organization selected among the collaborative that gets the funding from us, from the state, in terms, so they become the infrastructure, the glue that holds that collaborative together. It gives us, allows us to be accountable to the funding and to the funders. And so we channel the funding through that backbone organization, but they are expected then to use that funding to not only support themselves in that role, but support the collaborative and all of the activities of the health equity zones. So those are the current backbone organizations, and you can see they are very different depending on where we are. We have federally qualified health centers, we have mental health organizations, we have CAP agencies, and we used to have, in fact, cities and towns as backbone organizations. We've had the town of Bristol initially was, in fact, they were the backbone organization when they first applied, and it was the first time we had a grant that way with the city of Bristol. Providence, when they started, they had one city-wide one that was also at the city level. And so that's been an interesting evolution, and it's important to recognize that. But the importance, the common thread to all of the health equity zones is to have that agency, that organization that supports that collaborative process. The other thing that was important for us to do, it's okay, this is great, sounds good, but how do we know that it works? And how do we create measures that across the board are letting us know that things are changing? So we came up with what we call Rhode Island core health equity measures. We didn't do that on our own, which is why it took us almost 2 years in a partnership with our not only the state agencies that have responsibility for some of those measures, but with our local partners, making sure that these metrics that we wanted to hold ourselves accountable to made sense to them. And so those were the metrics. We identified the areas that we wanted to have an impact initially, from a healthcare perspective, from a community resiliency, really looking at civic engagement, policies, social vulnerability. Those were things that the community had brought up as being important. The physical environment, again, remember we're addressing the bottom of that pyramid, so the things that are important for people to have good life outcomes and health outcomes. And so the natural environment, transportation, socioeconomics, housing, absolutely, we know that continues to be a huge issue. Food insecurity, education, connected with jobs, and then definitely community trauma was something else that came up a lot in terms of discrimination, public safety, criminal justice. And so we have launched since 2019, we are tracking those indicators, and we have a report, in fact, that it's coming up soon that let us know how well are we doing after this investment. A key component of the health equity zones that I think it's important to talk to you about, if you go next. As we talk about our evaluation, we know that is a very complex, but we wanted to recognize that what's happening has an impact both at the level of the community, has an impact at the level of the not only building capacity at the community level and building capacity at the state level to do these things differently, but changing at the community level so we can have really the impact on those equity measures. So the next one that we're talking about, it's one of the key components for the health equity zones, which is the training and technical assistance program that we provide. So while that collaborative process is truly led by the community and we take that step back, but as we said, we want to support the community. And so we provide opportunities for training and technical assistance that is really based on the health equity zones themselves, what they feel they need, and what they ask us to be supporting them with. And those are the many different ways that we can do that, and that we do that, and we meet with them. We meet with the backbone organizations, we meet with all of the organizations in the collaborative. We have an ongoing engagement that has been truly building the capacity of our communities to take ownership of what they are doing and be that voice, strong and clear in what's needed to happen in our local cities and towns. So the next one, it's talking about how we are positioning ourselves in terms of scaling and sustainability for the future, and how we need to continue to expand and sustain what we have right now. We talk about how we wanted to have it be in every city and town, but we also want to have it beyond the focus to be beyond public health. It was one of the things that we've noticed. First 5 years, it was all about public health. And then after that, it really became a local infrastructure that has been used by all other state agencies, by the Department of Education when they needed to do local educational assessments, by the Department of Behavioral Health to address the opioid crisis that we have right now. We have partnerships with housing to address homelessness. We have partnerships with DEM to plant some trees and make our environment better. And so expanding the health equity zones to a whole of government approach, it's one of the lessons learned from COVID that we want to truly continue to have, and have the whole of government see that the health equity zones is this local infrastructure that can be used. The same way we want to see for you all at the municipal level to be able to see how the health equity zones infrastructure that is being created, it's an infrastructure that provides you with resources from not only health and human services, but across the board in terms of training, employee training, job training programs, addressing the environment, helping with transportation and all of that advocacy. So that's some of that scaling that we want to have for the health equity zones. And then definitely making sure that we continue to invest, as we said, upstream, so over that bottom of that pyramid, so we can have the transformational change that we are to achieve in the future. So the next slide. We knew that we needed to create a toolkit to support localities in doing what they are doing. We wanted to have folks to be able to replicate on their own and continue to invest on their own. And not only in Rhode Island, but we start getting a lot of calls from other states and other cities and towns across the US about how do we do this thing that you guys are doing. And so we developed this this toolkit that really goes a step by step how this can be done and what are the necessary processes that need to be put in place. And before next one, I think this is the last one. That's a implementation and evaluation timeline. It's more of our internal processes of how we've been doing and evaluating and assessing. That's a picture of what I was talking about. So you can see how at the national level, we've had all kind of requests for support to do the health equity zones that led to that toolkit. And that toolkit has been distributed to, I don't know how many places. And even outside of the US, we've had requests for how to do this work. So Little Rhode Island, it's really through the health equity zones, putting a very clear dot on the map on how to do this local community transformation in a way that supports communities and supports the people in our communities. The next slide,
I believe that's the last one.
The next one. And so before I address some questions, I wanted to just share with you some examples of municipal partnerships that we've had so far, how using the health equity zones. You can stay on that other slide because you're using the other version. How bringing those resources into cities and towns that help solve local level problems. We've had responses, so we have so much that we've been doing that I couldn't do all of it with you, but I wanted to talk about, lift up from all of the work that the health equity zones have been doing in the areas of, for example, mental health and the drug overdose response. And we have examples from Pawtucket Central Falls, from Bristol, from West Warwick, from One Cranston has, from the Washington County has, where they have partnered with local police and peer recovery network to do, for example, in Pawtucket, they do monthly review of data, and they use that to drive action both from the peer network, recovery network, and from the local police, helping them respond to crisis. From fire and police partnerships to create a behavioral health navigator program, for example, working with the cities to provide recommendations, you know, how we have the opioid settlement funds that the state has negotiated, of which a percentage is set aside for cities and towns. Some of our health equity zones have come together with the residents and provide recommendations for funding to the cities, of saying, these are the things that are important to do. Or focusing on Narcan distribution, for example, on how to do that reverse drug use that we have, reversing drug overdoses. That's one example. We've had HES is focusing on housing and economic development as another area. And they've worked on amending zoning ordinance based on HES recommendations. They have increased resident involvement in advancing housing policy, for example. providing TA to advance upward mobility, access to quality employment, and addressing racial equity issues. Housing, one other has done housing affordability study and broadband survey supporting. I believe that one was maybe East Providence. I forgot which one was. Newport, maybe, doesn't matter.
Central Providence.
Central Providence, there you go. And then we have them be part of housing and homeless response. They have done Pawtucket, Central Falls, and Providence. They engage in a participatory budget exercise where they decided to support, for example, park improvements, and they have bought outdoor gym equipments to be used, or doing a splash pad. They've done mental health campaigns through that participatory budget, and they did murals, for example, on retail buildings, focusing on mental health. We had some other collaborations, such as school-based activities. Our COVID-19, it was amazing to see the response and the difference, the impact that where we had a health equity zone and where we didn't have. They have things such as community improvements and thriving communities, beautification projects, enhancing creation of public spaces, school improvements. I believe Cranston did Active Streets for All process, or technical assistance for street revitalization planning, becoming a child-friendly city. Those are examples. Environmental budget. Environmental management, from increasing, there's one equity zone, I don't remember each one. They did increasing beach access to persons with disabilities, for example, tree planting events. And that led, in fact, now to the state applying to a grant to do a whole forestry grant that we're gonna be starting in collaboration with cities and towns and with DEM. Climate-related grant collaborations. So those are few examples. And when I say a few, it's truly a few, because I could spend the whole hour just sharing with you all of the examples. But at the end of the day, I think the big message that we wanted to give you all, and Chris, join me in any way, is to say that this resource that we start investing in and building at the local level 10 years ago. It's a resource that is to be used by all. It's to be shared by all, but it's also to be invested by all. For example, as we see the new funding that the cities are receiving to build the community centers, learning community centers, health equity zones are a natural partner to help you. Once you build that space or you renovate that space, they can be there providing services. They can be there as bringing the community in. That is one of the requirements to have a community engagement. They are your community engagement. When you don't have one, you don't need to start from scratch. You can use those resources and collaborate and partner in either more ways that you've done so far. So we wanted to make sure that for those who have not had the exposure to EOHHS, that we had this conversation and that we share these with you. And I am so proud of what started 10 years ago, in fact, as an idea at the health department, and that turned into, by their own work, in this amazing local infrastructure that is truly, truly making a difference in the communities where they exist. So thank you for having us, and I will see if there's any questions.
Thank you, Assistant Secretary. That was very informative. Let's see, I do see one in the chat. Will there be an expansion of the program to additional towns?
So that's the goal, definitely, to expand as much as we can to all cities and towns, as we said, at minimum, and hopefully to have it in, when makes sense, in a smaller scale. We are continuously looking at how to sustain that infrastructure. we have made a commitment to sustain the infrastructure, and the health equity zones as collaboratives, in fact, have gone after funding to implement much of the action plans that they come up with. So we are continuously working on funding, on grants, on applying for federal funding, working with our state government to have funding that is not specifically allocated to a program, but more allocated to this infrastructure, working with local foundations and national foundations to bring some funding and to be able to continue to expand. That's the goal. Sustain and then expand.
Great. Another question there, is there any thoughts on regionalization for these programs?
So we really leave it to the community to decide how they want to do that. For example, if we go to that map, you can see that some are two cities, Pawtucket, Central Falls, came together and created one single HES. County, tri-county, they are a county level HES. So they have multiple cities in their collaborative, and they work with all of those cities. And so, yes, there are thoughts. People can organize their collaboratives in whatever shape or form they want. One city, 3 cities, county level, or neighborhood level. One requirement we have is that it has at minimum 4,000 people in that area. So it has meaningful impact because we want to be able to show impact.
Okay.
Chime in on that and the prior question. The infrastructure, I think, presents also a distinct opportunity to communities, not just to react to what we can find as the state and what resources we're able to draw down, but as the community goes through that process of establishing an action plan and defining and determining this is what we need. And building the capacity between residents and resident leaders and organizations within the community, not to fight over the resources that are available, but to say, hey, where do we find what we actually need to drive the type of change that we need to achieve for our community? It presents this opportunity for both local and national funders to invest in Rhode Island communities, right? And we're seeing that happen, and we're seeing this national attention towards this bottom-up drive for community transformation that national funders are now very excited to invest in. And I want to put that out there as a great opportunity. And from the state's perspective, we're not prescriptive about what that, sort of regionalization or what that structure looks like. We're there to be supportive because we understand that the change that needs to occur to move from hoping that things will be better to actually achieving change, it really starts with the people, right, of the state of Rhode Island, the people in the communities in the state of Rhode Island. What we're providing and what we're investing in is the establishment of the infrastructure that's necessary to organize those folks who are already doing amazing work to better define what are your needs, and to build the capacity and infrastructure necessary to gain access to those resources that are going to make those transformational changes. And that's that partnership. It's that constant partnership that we strive for between the folks in the communities, and sort of our role within state government, but also respecting and understanding that that's a limited role. We can't fix everything, we can't do everything, and sometimes we're not the best folks to be positioned, and really thinking about how do we ensure that the residents and the community leaders are the ones that are empowered, and not just empowered, but supported and resourced appropriately to do that work.
Great, thank you. Any other questions, folks? All right, not seeing any. I will just first give a big thank you to Assistant Secretary Novais and Chris for joining us today, and a preview of next week's workshop Wednesday. We will be joined to learn about the Rhode Island Recovery Friendly Workplace. So I hope you'll join me again at 10 next week. Same Zoom link, and I'll be sending out an invite to that. If you folks have any questions, please let me know, and I will certainly get those over to our speakers. And I'll also have the slides too. Thank you so much. And this session it is recorded and it will be uploaded to our YouTube channel by the end of the day. All right. Thank you so much. Have a great day, everyone.
Cool.